Good evening, ladies and gentlemen. It's a great honor for me to be speaking on the platform of the Sudanese Surgical Club, together with our 9th and 10th clinical radiology session. Our chairman today is Professor Mohamed al-Makki al-Rashid. Actually, he's Rashid in behavior and Rashid in name. Professor Rashid Ahmed Abdullah is a professor of surgery at the University of Khartoum, and he's a long-time surgeon at the Khartoum Teaching Hospital. Our topic today is the differential diagnosis of acute abdominal pain, the clinical and the radiologic aspects. Okay, can you hear me clearly? Okay, before I go further, I go to the commitment of Professor Rashid to this hospital, and I go to the history of Khartoum Hospital. Maybe you need to recall the history of these institutions before we go on to our topic. You know, radiology, which is my specialty, has entered into Sudan. It was the second country in Africa to have radiology, and it went from the north into Khartoum Hospital. Actually, it was the first Arab country to have X-rays performed. And one of the great work which was done in Khartoum Hospital was the fight against bilharzia and other tropical diseases and diagnosis of leishmaniasis, bilharziasis, and the other insect-borne infections. And that was, this plaque is in the wall of Khartoum Hospital, actually, to commemorate the work of Christopher Merson. Since 1917, he introduced the use of potassium antimony tartrate for the treatment of bilharzia. So Khartoum Hospital was there for a long time and was there with a lot of innovations. Now, again, I will take you to the late history or the mid-history of our hospitals and Khartoum Hospital. In the past, when VIPs, presidents, kings, and queens visit the Sudan, they are taken to visit 3 places, which are the nicest places in Khartoum at that time. I'm saying. First was the zoo, and second was Khartoum Hospital, and the third was the high girls' school in Khartoum. So now I'll show you the implication of these visits on the health services in the Sudan. This was President Tito of Yugoslavia. He was taken to visit Khartoum Hospital when he visited in the 60s. And he was shown around by the great man, Professor Halim, who was the senior physician and the director of Khartoum Hospital at that time. And that's a hospital. You can see the floor is shining at that time. The beds are so clean and tidy, flowers all over the place. I'm not going to describe the hospital now. Anyway, President Tito was so much impressed by the hospital, and he was taken to the zoo. He was also very much impressed. That was a peacock. When we were children, we have seen this peacock in the zoo in Khartoum, in central Khartoum. He was so impressed, he gave the Khartoum Zoo a bear, a polar bear. And when we were children, we went to see the bear for the first time. They were putting ice and showers all around the strange animal. And it looked so soft and so peaceful, but of course, nobody would touch it. And moreover, he saw that the hospital did not need any addition. So he gave the Sudan the chance to form a combined company. And he donated like 8 ships, 8 big ships, which constituted the Sudan line. Of course, now this is non-existent, painfully non-existent now. But anyway, that's the impact of his visit to Khartoum Hospital. It gave us the bear, the polar bear, and it gave us 8 ships cruising in the seas, raising the flag of my country at that time. Actually, I remember this because I sent my own luggage from Liverpool directly onto the Sudanese ship, and I collected it directly from the Sudanese ship in Port Sudan. I paid no other agent or air or sea line. And I came also on Sudan Airways. These services are non-existent now. That was about the visit of President Tito. The other famous visit was for the Queen of England, Queen Elizabeth. She was so young at that time, and she was taken around, of course, to see all those places, but she was very much impressed by seeing the high school girls. This is the painting session. They have special boards, there's special coloring materials, and they were drawing their natural drawings as, you know, as a part of the curriculum of the school. That was, at my time, that was compulsory subject. I don't know what's happened to it now. And beside the Queen was a great professor, Professor Tijani Al-Mahi. At that time, he was the head of the Supreme Council, Majlis al-Siyada at that time, because that was after October Revolution, which we took part of it as secondary school students. And we brought 3 great physicians into the Supreme Council, Professor Tijani Al-Mahi, Professor Abdul Halim, and Professor Mubarak Shaddad. That's the type of transitional government that we brought to the country. I'm saying no more about this. Okay, so what was the implication of the Queen's visit? Following the Queen's visit by so many years, her daughter came in. Her daughter came in to visit the country, Princess Anne, following the advice of her mom. And then there, the idea came of building a pediatric hospital, a pediatric emergency hospital. And the hospital idea was adopted by Professor Ja'far ibn Auf, great man, okay? And he built the hospital. The sweat, I saw this myself. The sweat from his forehead has mixed with the cement used to build this institution. So his name must stay there. His name cannot be removed from that place. So that was the implication of the Queen's and the Princess visit to our hospitals, zoo, and other places. Okay, what else has happened in those great times? This is Khartoum Hospital, where Professor Rashid was one of the major guardians to that institution and to the good practice in that institution and in Sha'b and in Soba. Anyway, what happened is that the Russians at that time, it was only one country, one big country, they got impressed again with our October Revolution. And they got impressed, their ministers visited our country, they were impressed. So they gave the Ministry of Health a gift, which was Soba Hospital. At that time, the hospital was way out of town, and Ministry of Health did not have enough staff to send them all the way out and all the way back in here. So the Ministry of Health said they could not run it unless they get more staff and a big budget. So the university stepped in, and these great men, Professor Haddad, Professor Umar Bilal, Professor Lider, they took over the business and they mobilized Soba Hospital, which was complete gift. Actually, there were even staff from Russia there in the X-ray, in the anesthesia, and in the laboratory. They were given as, you know, a donation for like 10 years or so. So that was the story of Soba Hospital, and these are the great men which built that hospital and built the good practice in that institution. Going back to Khartoum Hospital, there are other guardians, eminent gentlemen who kept the flag high, who kept it going, the nursing and the doctors, the clinicians, the technicians, and the patients. Look at this patient lying so quietly in bed, right? No shoes around, no mess, clean floors, okay? So what happened then? One of the royal family was one of their daughters or whatever, or niece, I think, from the royal family of Japan, was the wife of the Japanese ambassador in Khartoum. And it so happened that she developed acute abdominal pain, which is a topic of our presentation today. She got acute appendicitis. And they were trying to fly out of the country to go to Japan, which will like 18 hours flight or so and so. Anyway, finally, one surgeon from Kordofan, okay, a senior surgeon, he convinced them to have the surgery because it was very risky for the young lady to go all the way and get her, you know, complications like perforation of the appendix and so. So, well, was half-hearted, they accepted, he operated on the girl or on the lady, and she recovered very quickly without any complications. And then she flew home very quickly. And when they went there, she had full investigation to make sure that there was no complication of the, and they were impressed by the cleanness of the surgical technique which was used. This is Professor Zakiuddin Ahmed, the great man, one of the, again, custodians of Khartoum Hospital, those who built the great name and who trained so many, and who used his own personal relations to send others to train in UK. Moreover, I have to mention the other great man, Ahmed Abdelaziz, again, who have sent so many young surgeons to Ireland and to England for training. Again, this is Professor Daoud, who has been the model for all good practicing clinicians. This is Professor Ahmed Mohamed Al-Hassan, the most accurate of pathologists that ever walked on earth. Okay, we go forwards now. History, our young people must know the history, where we came from, what we were doing. Our topic today is a differential diagnosis of acute abdomen. What is acute abdomen? Acute abdomen is a sudden severe abdominal pain within 48 hours or so. Some people say 2 days or 3 days, but to us, we take it as 24 hours as a limit. From this presentation, I'll exclude the traumatic pain, the blunt trauma, the penetrating injuries, the polytrauma cases, the seatbelt injuries, which are all very important, but we cannot cover all these things today in here. You can read about this in Radiographics, a good article about traumatic injuries to the abdomen. The other thing which I'm not going to talk about is the abdominal manifestations or complications of COVID-19, because I have covered this before. And this topic actually is evolving. We're still learning from it. Maybe later on we can do a presentation on the same topic. So acute abdominal pain is very common. It's very common. It's a daily encounter in the emergency department. Up to 1972, plain X-rays were the only available diagnostic tool. There was no ultrasound, there was no MRI, there was no CT. And X-rays were thought highly of. But of course, by time, things have changed. Initially, this is an X-ray, which can show thumb printing in the region of the distal transverse, and the splenic fracture, which is a watershed area, as you know, and this is an ischemic colitis, which can also, in some advanced cases, it can involve the transverse colon. But mainly, usually, it's a splenic fracture and the descending colon. This is plain film. This is a water-soluble contrast study. Okay, some people use barium, but it's not wise to use barium when you have colitis like this. And this is a CT showing the thickened, multi-layered bowel due to edema and differential enhancement of the mucosa compared to the edematous submucosa. Now, the causes of acute abdominal pain are variable. They can be self-limiting, but they can be life-threatening. life-threatening conditions. This is why we should be very keen to diagnose them very early using all available diagnostic tools. In the modern ER department, there is a challenge because management is supposed to be complete within 4 hours. No ER officer is allowed to keep the patient for 4 hours in his unit, either cleared inside for admission or discharged home. And that's putting so much pressure on the ER officer. And the ER officers are passing this pressure on to us, the radiologists. So the busy ER officer has got a short time between thinking, what is the problem? Oh, yeah, is it pancreatitis? Is it colitis? Is it renal colic? He has got very short time between thinking and taking action. And that's put pressures on him. So what happens? What is the role of imaging? The role of imaging should to decide for the surgeon whether to operate, when to operate, and whether not to operate. Okay? I will show you examples as we go on with this. Okay, if we go to the causes of acute abdomen, there are 8 causes, 8 which are representing 80%. Everybody knows them. Appendicitis, cholecystitis, urinary colics, bowel obstruction, perforation, pancreatitis, diverticulitis, salpingitis in the females, and non-specific abdominal pain. Actually, this is the commonest presentation. Patients are not good historians. So he tells you the pain is here and here and here, and he keeps changing his mind. There are self-limiting causes, which no need for surgery. Surgeons, even if they see an abnormal X-ray, should not operate. If it's just gastroenteritis, or somebody's got lymphadenitis associated with that, or if it is appendicitis, I show you examples of that, or if it's an omental infarct, it can be very painful, but no surgery, conservative treatment, or if it's a metabolic syndrome like the diabetic autonomic crisis. And there are life-threatening causes. These are the most important. If you have a bleeding aortic aneurysm, you have no time to waste. It's a life-saving diagnosis and a life-saving intervention. Pancreatitis is a very serious complication, very serious, general and local complications, vascular, renal failure, shutdown, etc., etc., etc. Bowel ischemia can proceed to gangrene if not diagnosed early. The peptic ulcer perforation is very common, and you have to make a quick diagnosis with that. Perforated diverticulitis is rare. It tends to seal the perforation of the diverticulum, unlike the perforation of the peptic ulcer, but can occur. There are other rare causes, maybe common in children, like the intussusception. Internal hernias are rare, but they are very important because they are very difficult to diagnose, very difficult to diagnose. You need very experienced surgeon, very experienced radiologist. And the appendicitis we mentioned. There are conditions which occur exclusively in the neonate, like this condition, whether it's duodenal atresia, whether it's rectal atresia, whether it's ileal atresia. I think we have to do a session separate on the obstructions in the neonate. There are some postoperative pains. We may touch on 1 or 2 of them, but that's again a different category. Emergencies, yes, there are medical emergencies, not only surgical emergencies. There are things that need urgent treatment. We'll try to show you 1 or 2 of these. One of the most important things with radiology, particularly with CT, is to raise the red flag if there is the hypotonic complex syndrome or the hypotonic shock complex appearance on the CT. And that has got very special signs. One sign is a collapsed IVC. You see that the IVC is almost empty. It's very thread-like. Usually the IVC is larger than the aorta. Here it's so small. This means this patient is actually in shock. So you have to resuscitate very quickly. Very quickly, you have to resuscitate this patient. Another example is the excess enhancement of the adrenals on either side of the midline. You see they are enhancing more than the liver, more than the spleen. actually decreased spleen enhancement and liver enhancement is a sign of hypotonic shock. Okay, so these are things that we could identify to raise the alarm for immediate resuscitation before time is lost. Of course, this is the old eye view. Still, those of us who go to the districts must be able to use this objectively. This is a ureteric stone shown by eye view obstruction, because mid-ureteric stones are difficult to see on ordinary X-rays. Back to the question of acute abdomen. It represents 10% of all outpatients coming to the ER. It's a difficult diagnosis because there is a broad differential. You will see so many cases. And history is diamond non-specific. The tenderness, patients will not allow you to examine him carefully if he has got tenderness and severe pain, and that creates a problem. The lab tests, again, are non-specific. You can get things elevated in different situations. So the ER physician in this situation, he can decide the degree of the pain and the location of the pain, but not the actual cause. Actual cause should come from the radiologist. But if he gives us the location, if he would give us the degree of the pain, is it severe pain, mild pain, okay? And in these situations, a quarter of the patients would require surgery. Therefore, it's very important to make a good diagnosis. And the mortality rate was reported as 2.3% from all those coming with acute abdominal pain to the ER. So where can the ER physician find help? This is the latest guidelines written by about 30 people from top institutions in Europe. Okay, and that's what they came up. I think this is more confusing, and the busy ER physician has no time to read through this jigsaw puzzle. So we try to answer this. We have our own suggestion if we find time later on. Okay, we go forwards. Most important, as I mentioned, is that the ER physician finds for himself the location of the pain and the degree of the pain. For example, right hypochondrial pain, we think of gallbladder disease. Right lumbar pain, we think of renal disease. Right iliac fossa pain, we think of appendicitis. Left iliac fossa pain, we think of diverticulitis. Now, central umbilical pain, I want to draw your attention to this. This is the area where most serious problems will cause pain. Central abdominal pain is the real emergency because it's a puzzle there. You don't know, is this pancreas? Is this the aorta, which is rupturing? Is this an abscess? Is this peritonitis? You can't tell. So you try, say, epigastric pain, we think about peptic ulcer disease, etc., etc. Backache, if it's not a disc, if the patient can walk, but he has severe pain, okay, walks comfortably, then you think of pancreatitis. Sometimes epigastric pain can be due to cardiac causes. We have to be very careful, and they may even vomit. So no waste of time, transfer them to the cardiac suite. And so on and so on. Low pelvic pain, hypogastric pain, gynecologic conditions. Okay, so the exact size of the pain, if you find it for yourself and you describe it to your radiologist, will help doing the right test at the right time, rather than go for X-ray, then go for ultrasound, then go for CT, then go for MRI. No, if you tell me that I'm suspecting that this pain is in the right iliac fossa, it has gone tenderness, rebound tenderness, etc., running down to it, then we'll go on and do ultrasound for the appendix. If you say, oh, this like pain from the right loin radiating to the testicle, oh, this is a stone, we go for CT KUB. Or if it's not available, we will go for X-ray. Pain location sometimes may be misleading. We don't take it for granted because remember there are three types of pain. There is the visceral pain, okay, by the autonomic nerves, and that's due to distension or spasm. It's not related to inflammation or irritation. That's very important, okay? It's usually dull and vague and usually causes vomiting. There is a somatic pain. This is from the parietal peritoneum by the somatic nerve. This is sensitive to inflammatory processes. That's why you do the rebound tenderness. You press on the appendix, patient's eyes are still open. If you raise your hand, then, which is now people find it very, very, very unfair to do. They shouldn't do this to the patients, as long as you can do ultrasound to see this. So a rebound, appendix goes to touch onto the parietal peritoneum, and then you get somatic pain. Then the referred pain. Referred pain is from the crowding of nerves in the spinal cord columns. Okay, therefore you get biliary colic going to the scapula, diaphragmatic subphrenic abscess in the 10th day after surgery that goes to the shoulder, back pain in pancreatitis, and so on. Now, when you go to the X-ray, when you go to the CT, you have to look for the pattern of bowel gas, whether it's small bowel problem, whether it's large bowel, whether it's free air in the peritoneum. I think air is a gift of God for us so that we can breathe, okay? It's also a gift for the radiologists and for the surgeons, that you can study the natural status of the abdominal structures. Here we are, straight away we can say this is a small bowel. Why? Because it is central and because the valvulae conniventis are all the way from wall to wall. Unlike the hostra. Hostra do not go from wall to wall. They go halfway, okay, to meet the other hostra. So this is central, small bowel obstruction. This is large bowel, peripheral, the location. This is, of course, an enema. This is not obstruction. This is an enema, double contrast enema with Buscopan or glucagon, as the bowel is relaxed. And this is a follow-through, barium follow-through, dilute barium. Shows you, again, the valvulae conniventis. And here you can see the hostra. So there should be no confusion whether it's small or large bowel, okay? Now, using the gas to detect all serious diseases is very important. And here we are. This is the double bubble appearance of gas in a neonate. That's consistent with duodenal atresia. No question, no need barium, no need endoscopy, nothing like that. It's a double bubble sign. Again, if you have an obstruction in the superior mesenteric artery syndrome, which presses the third part of the duodenum against the spine, you get distension. Of course, this is distension with water, but you can see the air pattern again, distended first, second, and half of the third part of the duodenum. Now, the most important and the most dangerous air to see is air in the superior mediastinum. And that has come from the esophagus. And that's a very serious complication. Not only that, this is, I think, the surgery of the esophagus is the most difficult surgical procedure on common practices in the hospitals. And I have to raise my hat to Professor Rashid for his dedication to these difficult surgeries, the malignant, the traumatic, the inflammatory, the interposition of colon replacing the esophagus. He's done a great work, and he kept doing this back-breaking procedures for a long time. This type of complication of air in the mediastinum, okay, is due to rupture of the esophagus. Fortunately, this was rare in my country because this occurs with those who go binge drinking on Saturday night, over drinking, you know, and then they start vomiting, and then the pressure of vomiting, they tear their esophagus. And if they are not brought to hospital early, they, you know, but mediastinitis is a serious complication, and that may end up they losing their lives. So I hope Professor Rashid's carrying on with the great work. And this is the example of leakage of contrast to do that. The other value of air is in assessing the biliary tree, where you can see air in the biliary tree, air in the gallbladder, okay? And we will come to discuss some cases later on as time permits. So that's the value of air as a gift, okay? Now, more use of the air. Perforations, I think our surgeons must remember always, they are not chest physicians, but they must look at the chest x-ray. Any patient coming with abdominal pain, please look at the chest x-ray. Maybe when you ask for it, people, they say, oh, why do you want with it? No, I want it because the chest x-ray is best to show you perforation, free air under the diaphragm. If the patient can stand, okay, but if he's ill, he can sit and you do the x-ray while he's sitting. But please ask them to let him wait for 5 or 10 minutes so that the blood rises up under the diaphragm. Because if they do the quickly, you will not see the air and you will miss the perforation, which is a major finding, okay? If he cannot sit, he's very ill, you put the patient on his side, the decubitus position. And then you can see free air, you can see if there is obstruction, fluid levels. Again, this is the step ladder fashion, the fighting small bowel loops, okay, which are due to intestinal obstruction distally. This is stomach, of course. This air fluid is the stomach. So we've seen the use of air and plain films, okay, to detect this pneumoperitoneum or bowel obstruction, okay, and we have seen the x-rays helping us to find the large renal stones, maybe the small ones, we cannot see them. The problem with plain films is that small amounts of air, you cannot see them. No way you see this on x-ray. And you want to operate at this time when that leaking has just started. You don't want to wait till the whole abdomen is filled and there is peritonitis and what have you. So therefore, CT comes in here for acute, particularly, as I said, central abdominal pain. So plain films are good, but they are not completely sensitive to all conditions. One of the common diseases in my country is sickle cell disease, and I want you to pay attention to that because they can come with acute abdominal pain. They have so many causes. Gallstones, very common, particularly young. You find very young teenagers with gallstones, okay? Vaso-occlusive crisis, of course. They get chest syndrome, they get abdominal syndromes. They also get papillary necrosis, don't forget, in the kidney. And that can drop and cause colics and cause stones. And of course, they get bone infarcts. That, again, it will cause referred pain like central abdominal pain, okay? And maybe mixed with pancreatic pain. And I like this X-ray. I show it so much in so many meetings because it tells the whole story. One-stop shop, as the Americans say. It shows that there was avascular necrosis to the right femoral head, which was replaced. And there is also biconcave vertebrae. There is autosplenectomy. And there are sutures here of cholecystectomy. This is only 23 years old girl, okay? So these are all the complications of sickle cell disease. And you can see again changes in the spleen, autosplenectomy, and you can see the osteopathy, the sickle cell osteopathy, the bone changes, which are quite obvious on this CT. Other uses of plain films is to look for foreign bodies. This we don't like to mention, we don't like to see. This is a retained gauze, forgotten gauze inside. People did not make a good count, and that's very serious, okay? This one is a forgotten scissors. This is not from my hospital, this is not from the Sudan, this is from France. You find this in the literature. All of these I got from the literature. So no blame here, okay? And that's a coin. It's a common thing to happen, kids swallowing coins. But I think now we have shortage of coins in the country. When we were young, All the money we used was coins. Okay, we go further. Where we shouldn't do, I'm telling you where things should be done, where things should not be done. This is the patient who is hemiplegic for a long time, and he's got distended large bowel. He's bedridden most of the time, and they ask for CT to exclude obstruction. Of course, this was not justified because this is only a loaded cooler, which they can diagnose on plain films. So no, don't do CT for those who are bedridden, hemiplegic, okay? And they need just X-ray, and they need digital evacuation to relieve them. Otherwise, they can get colitis by friction with the hard stools. So plain films now are mainly used for these elderly and for foreign bodies and to screen obstruction, but CT is coming up. Now I take you into a very serious condition. This is a life-threatening condition, and the diagnosis is $1 million diagnosis. Here we are, over distended stomach with air in the gastric wall. This is emphysematous gastritis, and this is best shown on CT. You can see the air in the wall, not in the stomach, in the wall. And that's a very serious disease. They treat conservatively but intensively, because if not, if it goes to gangrene, then it will be total gastrectomy, and that will be a disaster to the patient. This patient has already become toxic here. You can see he's got an ileus in his small bowel. Okay, more about the choice of, can I just make a short note here? I had to send a message to unmute Professor Rashid because I need him to stop me time. Okay, situations, choice of surgery or no surgery to be dictated by radiology, not by the surgeon himself. Okay, نتطاول شوية. Right, this is a volvulus. This is a cecal volvulus. The evidence is that it's curved facing right iliac fossa, where the root is. And the peak goes to the left upper quadrant. Whereas with sigmoid volvulus, the base and the root is in the pelvis, and the peak goes to the right upper quadrant. Okay? What is the difference between the two? Both look like coffee bean sign. This type of volvulus, which occurs in younger people, should be treated urgently surgically. Why? Because there is twisting. It has a long redundant mesentery. It should not have that. That's why it's getting a twist, just like the ovarian twisting. And it may strangulate and form ganglion. Therefore, this is an emergency situation. Whereas the sigmoid volvulus occurs in elderly people, bedridden. Look at this man, has got bilateral hip replacement. Bedridden, like the ones I showed you there, who has a fecal loading. And that one, you do a barium enema. For this patient, you don't do any barium studies. You do nothing. You take the patient to the surgeon immediately to operate on him. Here, we do barium or better water contrast. And you can see, if you see this peak, you know this is just a narrow area. You can pass a soft tube in there and it will deflate. Sometimes the contrast column itself can open the way and untwist it. So this is for surgery, this is no surgery. Okay? And the plain film diagnosis, no CT, no MRI, no ultrasound, straight away from here. Okay, more about the gas in the abdomen, more and more and more. Sometimes there is no gas in the abdomen. Oh, what's that? If the abdomen is gasless, it means that it's either filled with water or there is peritoneal irritation, so patient vomits all the air he has and passes diarrhea like gastroenteritis. Okay? Ascites, like this patient with ascites, it presses the bowel, it leaves no room for air. Okay? Without obstruction, but there is no air there. Okay? Other conditions, if there is obstruction high up, like duodenal tumor, okay, or jejunal, proximal jejunal tumor, there is no air. So the air comes from, we swallow it. I am now swallowing air as I talk. You swallow air as you brush your teeth, or you talk, or you breathe, or you cough, or even when you eat, you swallow some air. That's why there is always air in the stomach. In this obstruction, no air there. So we have to be careful when we see that. Normally, there should be little air in the, there must be some air in the stomach and some air in the rectum. There must be. But sometimes there is so much air inside the peritoneum without perforation. This is the cases of recent surgery, cases of laparoscopy, cases of peritoneal dialysis. They will have air even for 3 weeks. This does not mean that there is perforation. We finished with the plain film and the value of tracing the air. Now we go to ultrasound. Ultrasound will examine the solid organs and any fluid containing structure. Okay? In each ER now there should be a fast scan. What does fast mean? Means a simple portable ultrasound machine which people can play around, and is focused assessment with sonography in trauma cases. You just want to see if there is free fluid, like that, or free blood, or if there is collection or abscess. Okay? And that's very easy to do. And all ER physicians should do that. But apart from that, they should not try. If you want to know whether the patient has got cirrhosis, okay, whether he has got regeneration nodules or he has got hepatocellular carcinoma of 1 centimeter, you send him to the radiologist. But this is your joy, to detect free fluid and channel the patient for urgent surgical intervention. So ultrasound can assess the liver, the spleen, pancreas. It is very good for jaundice patients, for renal problems, or for gynecologic conditions, particularly the ectopic pregnancy, but that's not our topic today. Right. If we go to the regions we mentioned before, right upper quadrant ultrasound is very good for the gallbladder and biliary tree, the liver, pancreas, and right kidney. And these jaundice, stones, hydronephrosis are the indications for it. Let us see examples. Commonest indication for ultrasound of the abdomen is for dyspepsia. And the commonest cause of dyspepsia these days is, apart from peptic disease, is gallbladder disease. Looking for cholecystitis. What is the evidence on ultrasound? On ultrasound, you can see there is thickening of the wall, edema, double layer of the wall. Maybe there is induration around the gallbladder. Also on CT, you can see the induration, inflammatory changes around the gallbladder. Thickening of the wall. But not all wall thickening of the gallbladder is due to cholecystitis and you take the patient to surgery. No. Patients who have got heart failure, Professor Rashid, can you unmute so that you can stop me or comment or anything? We need your valid opinion. Professor Rashid, can you unmute? I can't hear you. Yes, can you get Mohamed Abbas on, Ali? He's raising hands. Excuse me, some technical problems. We need. Lisa, Professor Rashid is not with us. Can you get Mohamed Abbas on? He was raising hands a short while ago. Okay, I have to carry on in the interest of time. So not every gallbladder which is distended requiring surgery, which has got thick walls, because if the patient has got heart failure and congestion all over, the gallbladder is no exception. If patient has got hepatitis, then he will also have thickened or edematous gallbladder wall. Okay, and is there Professor asked to unmute?
Sorry for the interruption, but I think the control of unmute of Rashid from you, because you are the host of this session.
Yeah, we did from our side.
Okay.
Okay, we're waiting for him to do from his side. If you can see on the screen.
Yes. Okay.
Okay.
Yes.
Ali, you keep trying till you get him on, please.
Okay.
He's on, Professor Rashid.
Can you hear me now? No?
Yeah, I need to hear that voice.
Can you hear me now?
Yes, I can hear you.
Okay, fine. Just a question about the fast. Is it done by the residents? I mean, the emergency residents. Is it? You have certain courses for surgeons, the emergency to do it. I mean, what is the relation between the radiologist and the surgeon as regards to fast? Because it hasn't been introduced here in a proper way in our casualties.
Yes, thank you for the question. I think this is one of the easiest thing to learn for the ER person, because in one day he will see 20 patients or 30 patients. He will build up experience very quickly.
Yeah.
Okay. Unlike other things where things are rare. Secondly, he is focused. He's looking for fluid, for blood, for collection or abscess. He is not looking for anything else.
That's right.
Therefore,
and how frequent do you need CT in the casualty? I mean, in a daily basis, the order of CT scan.
We depends. Of course, it depends on the indication for the CT. We have a protocol later on when to do CT, when to do ultrasound, and these things.
I see.
Yeah. Now, how long do you want me to run?
That's all right. Yeah, you can go on, Mohamed. Yeah.
Yeah. Okay. Please come in and stop me if it's you need any intervention or anything.
Okay. Okay.
Okay. So we said that not all gallbladders which have thick wall are surgical conditions. Some are medical conditions, and we should not operate on those. Now, the one peculiar thing that you can see sometimes is a huge gallbladder, like a case report. Okay, that's hydrops or mucocele of the gallbladder. Sometimes it's not infected and it's an accidental finding. But it becomes important if there is a distension of the common bile duct with it. Then we have a problem then, because that takes us to the painful jaundice, which we have to exclude pancreatic head mass lesions. Okay? And sometimes this gets infected and you can drain by cholecystostomy. Radiologists could do that for you. Okay? They can drain the infected mucocele or the severe gangrenous cholecystitis even. This is a spectrum of stones. You see this every day, of course. Everybody know that solitaire stones, multiple stones, pigment stones, mixed stones, pure cholesterol stones, fine. Of course, the trouble is not the big stones for colics. The small ones are the ones that can drop in the common bile duct and cause the severe colic. Biliary colic is a very painful condition. And there is this rare disease of adenomyomatosis and cholesterolosis in the wall, in this difficult name, Ashev's to viscous follicles in the wall. Recent application of CT is a dual energy CT, which in the past CT was too strong to see gallstones. But now dual energy, it uses low energy to detect gallstones and to detect gouty tophi and these things. And then it uses high energy to look at the bones. Yani as if you have a small lamp, you use it for the gallstones, and a big flashlight, you use it for the bones. This is the principle, simple simplification of dual energy CT, and it's coming into practice more and more. More of acute cholecystitis, double wall. This is acute calcular cholecystitis. But you can have acute acalcular without stones. And still it can be very serious. Can be very serious. But still, I think surgeons prefer to operate like 3 months later or something. Treatment is conservative. But if it forms a lot of pus, you drain that by cholecystostomy. So pericholecystic fluid collection is a sign of cholecystitis, whether there are stones or no stones. You can see debris. When debris form, they become irritant to the gallbladder. Although it was secreted by the bile, but it becomes irritant to the gallbladder and cause inflammation. Multiple stones. Right. Not everything floating in the gallbladder is a stone. There are two conditions I want you to remember. One of them, the famous ascaris. Yes, we have seen it in the gallbladder. We've seen it in the common bile duct. And actually, good gastroenterologists can go in and extract it, pull it out. What we don't have in our side of the world, but is common in China and the Far East, is this cholinersis. This is a very tiny, beautiful looking trematode. Very peculiar. It's a hermaphrodite. It has got seminal vesicles, it has got ovary, and it has got testes. All right, it's doing the job inside. Okay, much convenient. Now, this small, nice looking creature is precancerous in the biliary tree, usually associated with cholangiocarcinoma, very toxic to the body. And it's very small like this. People will say, oh, this is just biliary mud. But no, you have to be very careful. Look carefully. If it's one of those, it has to be removed very quickly. One other warning about gallstones, because everybody ultrasound, gallstones, is to be very careful. Of course, يمكن يسويها الراديولوجيست يقع فيها السيرجن. Okay? And the stone, people must look around. Is there a tumor around the stone? Look at this. Somebody puts a probe here, he will see the stone. Oh, gallstone, quickly. No problem. No, there is a big mass surrounding the stone. So make sure you look at the gallbladder very carefully. Mass filling the gallbladder. It looks like biliary mud, but if they run Doppler, they will see this is hypervascular. Oh, tumor. They will see distortion of the liver. Oh, that's tumor. And here we are, a stone. It was seen. This is one case we had a long time ago. Big stone. But if you look carefully, oh, there is something in the liver here, growing from just the margin. Gallbladder looks okay. Here, it's got some debris and stone, but this is a cholangiocarcinoma. Very nasty. Cholangiocarcinoma is one of the nasty tumors. Okay, jaundice, of course, we do ultrasound. But when there is painful jaundice, it's more favorable, okay, to find stones rather than find tumors blocking the common bile duct. So very quickly, you do ultrasound, you do CT or whatever you do. Some people have MRI. They can do MRI looking for stones. This is a stone in the common bile duct, in the lower end of the common bile duct. Look at this here. The pancreatic duct is normal. Here is the pancreatic duct is normal. Very important to see the pancreatic duct, because tumors, unlike stones, tumors, if they grow here, the region of the papilla, they will hit the two to give you the double duct sign of malignancy. Here we are, ERCP. You don't have to do ERCP for diagnosis of stones. You do it for removal of stones. Gastroenterologists, okay? We have great gastroenterologists in our country. okay, men and women actually, led by Professor Suleiman, okay, and they can pass the basket and remove the stones, whether they are residual post-cholecystectomy or whether they are primary CBD stones. Here we are. This is a common bile duct shown on ultrasound. It's common bile duct is very difficult to see in ultrasound. Don't blame the radiologist if he cannot see the common bile duct in a normal person. But if it's obstructed with a stone, it dilates. زي ما النيل الغاضب الآن, you will see it. Okay. Again, residual stones. All right. And please, before you remove the tissue, do a cholangiogram to make sure that there is no dropped stone, no resist, there is a residual stone here. So this is a very simple procedure and very good, because if you come out and this stone is there, then it's a bad news for the patient, bad news for the patient, and bad reputation for the surgeon. Okay. We go forwards. Another example of big mucocele can get infected. The other thing, you may get a more serious infection, emphysematous cholecystitis. You can see the gallbladder full of air on X-ray, and on ultrasound it gives this stormy appearance like that, echogenic, funny, dirty. They call it the dirty gallbladder because of the reflections of gas there. And you can see gangrenous gallbladder in here. Of course, this one you don't interfere surgically because there will be a lot of fibrinous material adherent to the small, but it will be a mess inside. So you can drain. Your radiologist can drain, do cholecystostomy, put the catheter in there, drain the green bile into the back. When everything settles, then you can remove this and go back, remove the gallbladder. This is an example again of pigtail catheter in the gallbladder to drain. Okay, there are 2 or 3 peculiar syndromes related to the biliary system. One of them is the Merisi syndrome. Our surgical registrars must know this very well because they ask them in the exam about. I have heard this before, okay? And you have to give the explanation. What is the Merisi syndrome and how it happens? A large stone gets impacted in the Hartmann pouch, and then it becomes leaning. It leans against the wall of the gallbladder, against the wall, and then it finds it erodes the wall of the gallbladder, sorry, and the wall of the common bile duct, causing air in the biliary tree. This is the Merisi syndrome. Another example of Merisi syndrome. It has eroded the gallbladder and now it's obstructing the common bile duct, causing obstructive jaundice. Okay, because usually stones in the gallbladder may not cause all the time jaundice because the CBD is patent. But when it goes there, it erodes and pressure. بالpressure بس تعمل obstructive jaundice. And then if it drops inside, then خلاص الطامة الكبرى. The other peculiar phenomenon is when the stone is here in the fundus, away from the gallbladder neck, away from the common bile duct. Another phenomenon syndrome. The stone erodes the wall of the gallbladder and then erodes the adjacent small bowel and drops in the small bowel. And then it starts moving inside the small bowel. It's usually smaller than this, but as it's traveling inside, causing erosions with hemorrhage and deposits of food, deposits of blood, it becomes larger till it reaches the terminal ileum, which is the narrowest part of the small bowel, as you know. When it reaches there, it gets obstructed. It gives the peculiar gallstone ileus. The gallstone ileus is a very peculiar clinical situation. If you find one case, you report it in the literature. And you know, most surgeons don't see more than 2 or 3 in their whole career, unless they are referral center like in Soba or in Ibn Sina, they get all difficult cases there. Okay, so this is the other syndrome. We finish with the Merisi syndrome. We go ileus, gallstone ileus. Okay. Now there is two things which we have to differentiate very clearly. Air, I said, air is a gift of God for us to outline the disease problems. Here you can see that the air in these ducts is more central within the liver. It does not reach the periphery. And that's quite typical for the dilated biliary tree. This is air in the biliary tree, air in the biliary tree. Whereas this is air in the portal vein. It goes to the periphery because the blood supply has to reach there. Okay? This is going that direction. This is coming this direction. Right? Therefore, air in the biliary tree is different from air in the portal vein branches. And the causes are different. Air in the biliary tree, our surgical registrars, we know that there are 6 causes, including blah, 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 cholangitis, etc., etc. Don't forget penetrating duodenal ulcers, posterior wall duodenal ulcers. When they penetrate, they can also penetrate into the common bile duct, which is, as you know, is a retroperitoneal structure with them. Okay, this is anatomy, surgical anatomy. You have to explain things by anatomy, not by their appearance. And air in portal vein branch, this is a very serious situation. It usually indicates portal pyemia, infection, severe infection, commonly from the appendix, neglected appendicitis, gangrenous appendix sending gas there. Right, I think we finished with the gallbladder. We've taken so much time with it. Now we go to the renal ultrasound. And the renal ultrasound is straight away, no problem. Kidneys are easy to see, okay, with ultrasound. Actually, when you get your residents to train, Professor Rashid, get them to look at the kidneys first to gain confidence, because everybody will find the kidney. But if they try to find the appendix, they will get frustrated, they will give up, okay? And if the kidney is obstructed, it will give hydronephrosis. It will be very easy to diagnose. No problem with that. Okay, the problem about the ureter, the mid-ureter, because there is a lot of bowel there. Okay, if the stone in the upper ureter, you can see. If the stone is in the lower ureter, you can see through the bladder. This is the bladder. Bladder acts as the window. Okay, and even as the vesico-ureteric junction, the stone can be seen through the bladder. Problem is the mid-ureter, and there is a solution for that. Mid-ureter is difficult to see on the X-ray. Yani if there is no arrow here, I may not see that this is a stone. And this patient has got no constipation. Other patients are constipated. You cannot see anything in this area. So what you do is do the CT. CT is very sensitive. Look at this tiny stone. We can't see it on X-ray. CT very easily. And not only the ordinary CT, this is the low-dose CT without contrast. We now use low-dose CT for ureteric stones without contrast, with half the radiation, less than half the radiation, actually. And the new ones, the ultra-low, is the same as X-ray radiation. And the ultra-modern are less than the X-ray radiation. So انتهت الحجة. CT gives high radiation and CT uses contrast. No, stones become very clear on CT, even on low-dose CT. Okay? And you can see if there is obstruction, there is hydronephrosis, and you can follow the stone till the lower end. The rule with stones, ureteric stones, you allow 10 millimeters, anything less than 10 millimeters might pass. And you can just follow it by ultrasound or by CT, low-dose CT, until it passes. But if it lasts for more than 5 weeks, or if the size is 10, this patient should not risk it. He should go for the urologist to remove the stone, either by basket or percutaneously. Okay, so urology is very easy with imaging, unlike the complicated gastroenterology problems. Here we are, staghorn stone with a lot of granulation tissue around it. This is xanthogranulomatous infection, pyelonephritis, and that's very serious. Sometimes you have to remove the whole kidney if it is advanced. Stones, simple stones, you can see hydronephrosis, ureteric stone, easily to see. Okay, stones, or again, this is non-functioning now, taqriban, or obstructive. Stones, you can see even at the vesicular junction. And if you have, large stone like this, you can see it on plain films. So if you are in the district, still use plain films. If you have CT, use low-dose CT. Low-dose CT, and should be cheaper to the patient, half the cost, and half the cost to the radiologist and the hospital. Okay, now we come to an area of daily encounter, appendicitis, or right lower quadrant pain. We talked about upper quadrant pain, which ultrasound was the master. We talked about loin pain, okay, where low-dose CT was the answer. Now we come to the right iliac fossa. Who can help us there? Of course, you can look by X-ray, but sometimes you can see an appendiculus if you are lucky, but this is rare to see. And the problem with the appendix is unpredictable. You don't know whether it's retrocecal, whether it's subcecal, whether it's a normal position, etc., etc. So it's very difficult to find. Fortunately, when it gets inflamed, it becomes more obvious. And if you don't see the appendix, it is most likely normal. And if it is abnormal, you will most likely see it. Okay? So don't hesitate to do ultrasound for appendicitis, acute appendicitis. What is the rule? The rule is that if it is more than 6 millimeters thick, then it's an inflamed appendix. Okay? If you have Doppler, you can see if there's hypervascularity. Right? But X-ray is not sensitive for these inflammatory conditions. Okay? And sometimes if there is appendicular mass or inflammation, even involving the cecum, and if there is small perforation, little air, X-rays cannot see. You need CT in that case. For the complicated appendix, you go for CT. For the simple first-time appendix in a young patient of 17 years, you can see it with ultrasound. If you don't see it, it's most likely not. Unless the patient is very ill, then the diagnosis is different. Here we are. I'll show you very clear. Look at this appendix. Nobody can miss this finger-like structure. More than 6 millimeters. Again, edematous wall. Actually, there is edema around it. Here, again, distended lumen, thick wall, double wall, target sign. Here we are with Doppler, hypervascularity, acute appendicitis. No problem at all. Acute appendicitis can be assessed with Doppler or without Doppler, just by the size. Okay? Again, you can check tenderness. And of course, we should not do rebound tenderness. It's a very cruel examination. But maybe one surgeon will do it carefully to teach the boys that the innervation is parietal here. Okay, so CT can show appendicitis, and even you can see this appendix here, very quickly kinked tip. Here we are, this is an inflamed appendix. Why we say inflamed? Because the mesentery, look here at the fat. The fat should be black and clear. The fat here is dirty fat. There is smearing around it. Again, another acute appendicitis here. And it's got a appendiculus. Can you see that? Appendiculus, like a stone. Right? Here we are, appendix going towards the pelvis. Okay? It contains an appendiculus. Right? And this is the most difficult one. This is the retrocecal. This is the cecum. This is behind the cecum, and it is inflamed. So it's good from the CT, we tell them. I never forget that when I was a house officer, we had a patient who was done by my senior registrar or whoever, and it took six hours to find the appendix. We had to get the consultant from home. Now, another retrocecal appendix, but normal. This is retrocecal and inflamed. So CT can solve the problem for you. Okay? If ultrasound did not give you the answer, CT can give you the answer, particularly with the retrocecal appendix. And I think it's becoming more common now than before, retrocecal appendix. Is that true, Professor Rashid?
Yeah, I think probably the CT might be helpful in patients whom you are not really keen to operate, elderly patients, trimester pregnancies. I mean, because I mean, the straightforward cases are, I mean, you might not need to do even an X-ray, but I think in cases where probably the diagnosis is a little bit, then it will be very helpful so that you exclude appendicitis instead of operating in somebody, or probably an elderly patient with an obstructed tumor causing acute appendicitis. Then here probably might, there is an indication for this, I see, because not available in the casualty. CT is not really, even in public hospitals, I mean, for emergency situations. But I think the plain X-ray can be very helpful because it's available everywhere. I think all the country hospital, they can have a plain X-ray. So reading a plain X-ray, I think, is really important for all the residents.
Yes, and ultrasound, of course. I think all setups which has X-ray now, the Sudan have ultrasound as well.
That's
So
right. I
again,
mean, ultrasound, as you mentioned, I mean, it's a simple thing available, and they learn it by practice. But I think it is important that most of the residents should be really acquainted. It's not really now a standard thing in our hospitals, but I think it is cheap and it is easy to learn, as you said, by practice.
Yes. Okay. Now, so this is more about the appendix, which should now be very clear to people. It becomes thick walled. It becomes, there is a smearing around it of the peritoneum. Look at the thick walled, full of fluid, okay? And sometimes there are some lymph nodes, small, should be reactive lymph nodes, not the large lymph nodes of lymphoma or malignancy. Okay. Now, sometimes, now MRI is coming up, but you know, of course, it's expensive. And although MRI is now, I've got so many MRIs in the country, but the indication for MRI mostly will be in pregnancy when you don't want to do CT. And actually MRI, because it's got soft tissue detail, is very good. It shows, look at this appendix. Look at the edema around it. Look at this appendix and some edema around it. This appendix has got even stones inside it. The dark ones are stones. And this is the fetus, okay? So in pregnancy, it's justified to do MRI. And in children, if you want to save them from radiation, they can afford, okay, why not? But this is not a routine practice. Now we finished with the right lower quadrant. We said right upper quadrant, ultrasound, gallbladder disease. Right loin, renal disease, ultrasound, and sometimes CT. CT KUB for the ureteric stones. Okay, and right lower quadrant, ultrasound. If complicated, we go to CT. What about the left lower quadrant? Two problems here are important. Of course, here you have diverticulosis, okay, which is outpouching, etc., etc. You know the mechanism of formation, but sometimes you get inflamed. When it's inflamed, it becomes thick-walled. It causes obstruction. And it causes toxemia even. Diverticulitis is a very serious complication. Maybe the surgeon might have to do diversion till this is settled. So we have to tell him if there is diverticulitis or not. Look at this, and they can form abscess. Look at the inflammation in the surrounding peritoneal reflections and the thickening and the obstruction. It causes obstruction, very serious. And it can cause perforation, air outside the colon. Tends to be localized, but it can be generalized, okay? And most important is to make sure that this is not a tumor. Inflammatory processes tend to be long segment, whereas tumor is short segment, like apple core cancer. Our surgeons know apple core lesions very well. And here we are. This is acute diverticulitis. This is the arrow sign, they call it, because it's tapering, thickening, and there is a pericolic edema and smearing of the mesentery. So this is diverticulitis, which is a very serious condition. And of course, طبعا زمان when الملوخية ويكا were the main diet, ما كان عندنا كده. Now diet has changed a lot. الله يرحم بروفيسور عبد العال كان يحذر من اللو فايبر دايت.
السكراين السوري.
And now people are now taking sandwiches and McDonald's and what have you, and then we're getting these complications. So
you are right, absolutely, now, you are right. It is coming up. I mean, the particular disease used to be an entity that nobody really think about, but now it is becoming an entity available. I mean, in the bleeding center in Ibn Sina and in the acute abdomen. So the particular disease is now coming. And as you mentioned, right, that the change in dietary habits, which is really bad. I usually tell our dietitians that they have got a role, I mean, to educate people about diet. Now everybody, because there is no, I mean, this Western type of bread, everything stops. It used to be just a luxury. I mean, in our times that, I mean, the kisra and the asida and the burrasa. So the bread is not a very important entity in our diet before, but now it is becoming, I mean, central. Everything will stop because there is no bread now in the.
I see. Yeah. Yeah, unfortunate change of habit. Okay, so diverticulitis in the left lower quadrant, and we do CT. Notice here, this is without contrast. Very quick CT, very cheap, okay, and very easy to read for diverticulitis and for ureteric stones. These are the main uses of low-dose CT. Here we are, we have to be very careful about something else in the left lower quadrant, whether there is diverticular disease or not. And this, you can see this upper core lesion now. Surgeons all know this upper core tight lesion. This is carcinoma of the sigmoid colon. Very common site here. Okay, we can see upper core lesions elsewhere, but this is a common site. And this is left lower quadrant. And we do CT without contrast. Look at this, we can see. Or with contrast, you can see it as well. Okay, so remember, left lower quadrant, do CT. Now again, obstruction. This patient came with obstruction. Plain films have said this is obstruction, but they did not tell us what is the cause of the obstruction. Surgeon wants to know. Is this volvulus? Is this internal hernia? Is it? And CT, in the past, we used to do barium enemas. Okay? In the past, we used to do, and you can see the upper core. Actually, it's called upper core, but it should be tunnel core, right? If you, Mr. Rashid, if you find any of your young people, let them do a paper about changing the name to tunnel core, because it looks like a tunnel. Upper core, we don't know what's upper like, right? But it's more of a tunnel. And it will be interesting to get this into the literature. Okay, now CT has come not only as ordinary CT, now there is CT colonoscopy. Actually, this is a patient I did at the Royal Hospital when I was there some time ago. And here you can see the tumor, and see the lumen, you can see the wall, you can measure the length, you can measure the width, and you give the surgeon a very clear understanding. He goes, he will decide whether he wants to do end-to-end, he has got his own rules, end-to-end, or he wants to do first divergent, whatever he wants to do. You give him all the information. And you can see the rest of the colon. Actually, this patient had polyposis coli, which is a predisposing disease for this cancer. So fantastic CT colonoscopy now. And I'm enthusiastic about this, and I always used to make jokes with our gastroenterologists who do proper conventional colonoscopy about the length of the colonoscope. Because we do this just with a pediatric catheter. We blow air inside and give buscopan, and then you do the CT. Some other time we can give examples of this application. Okay, now Cancers elsewhere, we mentioned that is common to see in the sigmoid. It doesn't mean that the other bowel is not involved. This is in the hepatic flexure at the proximal end of the transverse colon. You can see this tight tumor, apple core or tunnel core here. Another one, very tight, very rigid. And again, that needs obstruction. That surgeon has to go and relieve and help this patient. Okay, so CT is good when you are suspecting tumor, when there is severe obstruction. All right. Now, central abdominal pain. I mentioned, and I will repeat, central abdominal pain is always dangerous. Don't ignore it. If you get a patient with central abdominal pain, there must be a very serious problem. And I will show you examples. One of them is this bowel ischemia. And if you don't interfere with this, okay, then this will become gangrenous and you will lose the patient. Of course, you take your lab results, see the lactic acid levels, that will help you to suspect this. But the CT appearance is characteristic. Look at this appearance. Edema, very severe edema of the wall, target light, and swelling, and almost occluded lumen. Here, all the way. And sometimes you see so many layers, mucosa enhancing and then the wall enhancing. Ischemic bowel, very serious. You don't want to wait, because then you will have to go in and resect a whole length of the bowel. Whereas you want to go in, you may just deal with the artery, okay? Or remove a clot or whatever, or put a stent in there, and the recirculation is regained again. Another central abdominal pain, which is very serious. All central abdominal pains must get CT with contrast straight away, because you will either get what I showed you here before, or you get pancreatitis, and there are other more serious problems to come. This is early pancreatitis, stage 1, where there is just peripancreatic edema and swelling of the pancreas. Of course, in the young adults, the pancreas is big compared to the elderly. So maybe this is just young adult, the same normal size, like there is edema around it. There should be no edema at all around the pancreas. And then this is now very swollen and very low density. Look at this. This is normal density. This is very low density. Now the thing has spread. Look at the gyrotous fascias, the lateral corneal space. All are now filling with fluid. This is severe pancreatitis, getting worse. And now the pancreas has eaten itself. The body and neck of the pancreas are now totally necrotic. And the tail is floating in pancreatic juice. And pancreatic juice is very destructive to the tissues, to the pancreas itself, because it's made to digest the food. So it will digest here, it will erode the arteries, they can get aneurysm, you can get bleeding. And this disturbs the whole metabolism. You get pre-renal failure, which can kill them. Okay? No, he died of pre-renal failure. And the late complication, which is simple to deal with, is the pancreatic pseudocyst. You can just drain it by needle. Radiologists can do that under ultrasound guidance. Very simple. You drain it because you don't want secondary infection to go there. So these are different stages of pancreas, phlebotomus, acute, severe. You can read about this in the literature. Okay, again, central abdominal pain due to severe obstruction. We have to be very careful with that, because it can be due to tight, small bowel obstruction, right? Look at this, tapering, change of caliber. This is called the transition zone. When you see the transition zone and you mark it for the surgeon, he doesn't have to go and do laparotomy for 2 hours to find the وطلع اللوبس كلها بعد شويه يجي له post operative alias من الشد والجذب. You show it to the surgeon, he goes, of course he will do laparotomy first, but he knows where to put his retractor to open here and get his assistant in the right place to help him deal with that. One of the important signs is what is called when the small bowel is obstructed, it starts, the secretions become thick. It becomes like feces. It's called the feces sign. If you see small bowel, it contains like thick material like this or mixed material like feces. This is an obstructed small bowel, distal small bowel obstruction. The commonest cause is adhesions. And adhesions are much commoner, of course, in females because they go through more cesarean sections, more cholecystectomies than men. Okay, so central abdominal pain, again, whether due to pancreatitis, whether due to small bowel obstruction, must be investigated by CT. Whether it's due to now 3 conditions. ونحن ماشيين لسه في a lot of other serious conditions. This is one of them. This is a normal aorta. This is an aortic aneurysm. Aortic, this is a silent volcano, silent. And this is again about to rupture. And here we are. This is leaking now. This is, we don't like to see this in our X-ray department. So we rush this. It should go straight to the theater, not to the wall, because this is leaking aortic aneurysm, ruptured aortic aneurysm. Look at this, is all hematoma, and this is fresh rebleed on table inside the CT. Very frightening situation. Okay, so again, central abdominal pain, immediately do CT with contrast, either pancreatitis, either adhesions with obstruction, either ischemic infarcts or aortic aneurysm. There are more demanding situations. Straight away obstruction, sometimes you get this peculiar appearance. This is common in children, which is intussusception. Like in adults, sometimes you can see intussusception if they have polyps, particularly lymphomatous polyps. That can irritate the peristalsis and can lead to typical appearance of intussusception. Okay, and you can exercise the words, the spelling, intussusception, intussuscipient, intussuscipium. Okay. So in CT, rarely you see this. Rarely. Like in, you know, in adults, if it happens, you think of lymphoma straight away or other polyps. Okay. There are situations where the surgeons should be aware of. People who have recurrent telescoping type of intussusceptions, celiac disease or diarrhea or these things, they keep bowel going on. You cannot go and doing 3 surgeries on this, and next week he will come again with the same problem. So if you know you find this telescoping type of bowel, you just tell them to keep observe them, and then it settles again. This is very rare, but it can happen. And it can frustrate a surgeon if he goes to operate more than once in a patient. One situation which we will have to consider is the paralytic ileus, usually post-operative. Paralytic ileus involves, the characteristic thing involves the large and the small bowel, both small and large. Actually, from the X-ray you can tell, small and large. And you don't usually see fluid levels with it. So that's ileus, no surgery. Okay? Because it will be disaster. If you go and manipulate this bowel, it will go into more ileus. Because the ileus has happened from 2 things: the manipulation and the drugs that you give, morphia and the other paralytic agents during the surgery. Rare self-limiting diseases, no operation. Okay? Which is like this mesenteric fat infarct. It can cause pain. Look at this. The fat should be dark. Here it is inflamed. Cellular infiltration here. Therefore, it can conservative treatment. Rehydrate, analgesia, the patient will settle. But if you go in and try to deal with this, then it will break more. It will get inflamed more. Give it time to settle. The other self-limiting condition is what is called appendicitis. Okay? Where, you know, the appendages, coli, these ones, they can get herniating through the wall or whatever, and they can get inflamed. And they may form small abscess. But it's always localized. So you just give antibiotics, rehydrate, and it will settle down. Trouble is, if it's in the right side, people may think it's an appendix. But if you look in different planes with a CT, frontal view, sagittal view, then you will see it is not in the region of the appendix. So these are two conditions which are self-limiting. There are other emergencies or abnormal conditions which need medical treatment, medical assessment, and they can come with acute abdominal pain. If somebody has got mesenteric adenitis for whatever cause, granulomatous disease, viral disease, malignancy, they can come with pain. So these are not for surgery, but they come with pain, you investigate by ultrasound or by CT, you can see them, and then you refer them to the clinicians. Now we talk a little bit about masses. One of the peculiar masses is the mucocele of the appendix. You have seen the mucocele of the gallbladder. You can also have mucocele, retention of mucus in the appendix, and it can reach very large size, and it can have calcification in the wall. It's a benign condition, and you can remove it. It's better removed by refer to the surgeon for removal. Okay. The other thing that you don't want in the appendix is a tumor. Okay. Cystadenoma or cystadenocarcinomas are common in the appendix, actually. And it's a common as appendicular mass, apart from the infective type. And it can give you the characteristic, surgeons know this very well, the characteristic gel-like thick ascites. It is ascites that you cannot pour out. زي كده زي العسل أو زي الشمع. You have to تغريفة غرف. You have to scrape it out of the abdomen. And it's very thick. It causes pressure on the liver. حتى يعفص liver. Scalloping of the liver outline. Very characteristic. And of course, this ممكن يكون من appendix, ممكن يكون from the ovary. Ovarian cystadenoma of the in females. Okay? Pseudomyxoma peritonei causes scalloping of the liver, characteristic appearance. And the origin can be in the appendix. This is a normal appendix with contrast. Okay, other masses that you can show, this is a patient who came and he had central abdominal pain and we felt a mass. We did ultrasound and we saw this peculiar mass. It looked like a kidney, but it's not a kidney. His kidneys were normal. And on CT, it seemed to have a mass, peculiar mass going around the blood vessels. Diamonal lymphoma is a very cunning thing. It can go under the mucosa of the stomach without disturbing anything. وتبقى endoscopy negative. It can go around the blood vessels without blocking them. But then till it grows later on, then it causes severe complications. This is a mass around the blood vessels and the superior mesenteric artery branches, and with a lot of lymph nodes. Here, it's forming a mass. And when you do the PET-CT is very sensitive for lymphoma. And of course, lymphoma now is a curable disease. Therefore, you are encouraged to diagnose it very early so that the treatment will be more effective. Another mass, which is if in Europe is called gossypioma, دي بتاعت القطيعة. Okay, like in Sudan it's called shashoma because this is a forgotten gauze. It can come, patients can come with a mass. Fortunately, you've got the mass has got, they could have seen it with the plain film, but because the patient was feeling a mass and the doctor felt the mass, they sent it for CT, and that's very characteristic appearance. هذا هو shashoma or gossypioma. I'm sure Professor Rashid had never had such an accident. Now, other masses, 74 years with acute pain, central. I am still warning you of central abdominal pain. Immediately do contrast with CT. Don't let them waste your time by doing ultrasound here and then doing X-ray there and doing repeating this thing, etc. This is a mass which got calcification here in the center of the abdomen and has got metastasis in the liver. And the patient has got flushes and he has got asthma, bronchospasm. This is a typical carcinoid syndrome. Okay, due to carcinoid tumor. Carcinoid tumor can occur in the appendix, can occur in the mesentery or the small bowel. Sometimes it causes severe desmoplastic reaction and fibrosis. And of course, there are isotopes peculiar for this condition. Now, there is another problem which is very difficult, and I think we should do it some other time because it needs very good explanation, okay? Which is internal hernias. Very difficult to diagnose. Very difficult to diagnose or to suspect clinically, okay? And you can see the swirling sign here, as if the bowel goes, one part of the bowel becomes trapped. No blood supply here, and the blood and distended. Look at this appearance. And there are so many types of internal hernias. Maybe one time we do a special session for internal hernias. One condition which sometimes can cause, I brought it, it's like a mass, but it causes confusion with appendicular mass. This is what's called typhlitis, which is the necrotizing neutropenic colitis in patients who are on chemotherapy. Okay, so no need for surgical intervention here. This is not appendicular mass. And the CT appearance is characteristic severe edema with enhancement of the mucosa. One other important surgical complication which we should be aware of, particularly لأهلنا في الجزيرة, is a spontaneous rupture of the spleen. Either spontaneous rupture or abscess formation and rupture, or trauma and then rupture later on. And I think معظم الناس اللي بيموتوا في شارع مدني, we lose them in شارع مدني because they are farmers, they have large spleens, they have malarial spleens, and minor accident, then we lose them. That's example of ruptures. We're trying now to push and finish. This is an example of ischemia. Maybe ischemia needs a special session in the future. And this is another type of lymphoma with a characteristic appearance of lymphoma called the aneurysmal dilatation of the bowel. Very characteristic appearance. If you see bowel dilated like this, okay, and the patient still not vomiting, this is characteristic of lymphoma. And then you do the PET CT, very characteristic high uptake. One rare particular situation, if the appendix goes into the pelvis and forms a mass. This was thought to be an ovarian cyst. But on CT, you know, when you see a mass, you do CT. Because ovarian cyst, we diagnose it by ultrasound. And they can go and operate. But this one, look at this. This is a big abscess. And it's got a phlebolus. It's an appendix. This is appendicitis. Pelvic appendix forming a pelvic abscess. Very terrible situation here. And it can be misleading. يكون الجينيكولوجيست دخل يضطر يجيب السيرجن at a very late stage. But if you do the CT, you will see that characteristic appearance. This should not be confused with the other characteristic mass in the pelvis, which contains fat, a lot of fat. It contains tissues. It contains hair. It contains a tooth, hair, teeth, and dermoid cyst. This is teratodermoid cyst. Again, they can come with a twisted, acute twisted, worry to be confused with appendicular masses. This is bladder cancer presented like hematuria. Patient had a stone in the kidney, and people thought they did without contrast, and they thought that this is just from the stone. Actually, he had a bladder papillates tumor. One self-limiting condition, this is the third one, with fat. The first one was fat infarct. Second one was appendicitis. The third one is this condition, very peculiar condition now, is now becoming very famous, which is called paniculitis. It's just like fat infiltration of the mesentery. The characteristic thing that it might form like a mass, but does not displace the blood vessels. It respects the blood vessels. Therefore, this is a self-limiting paniculitis. No surgery for this one. Okay. Sometimes they say it's a precursor of lymphoma, but anyway, at this stage, it's benign, right? Colitis, don't forget, patients with colitis can come with acute abdominal pain. You don't want to operate on a patient who's got active colitis. Maybe later on, you can do total colectomy if you are suspecting cancer to develop. When talking about colitis, one has to consider other causes of colitis. We will do another session for it. Other common problems in surgery is the hernias. Of course, the inguinal hernias and femoral hernias are no problem. But the Spigelian hernia and the Richter's hernia, okay, these are the difficult ones, which CT might help you to diagnose them, okay? Because patients, you know, these days, nobody examines patients. Nobody has time to examine patients so thoroughly. Don't forget abscesses, liver abscess. Actually, this is a very peculiar patient. This patient came as appendicitis. Appendix was removed. This patient continued to feel ill, developed an abscess. When the abscess was drained, proved to be, this was brucella. Brucella is common in Saudi Arabia here. This was brucella. So one has to be careful. When they do the appendix, they must send it for tissue diagnosis. And they send it, but they don't look at the result. They assume it's a simple problem. Vascular infarcts, when the small bowel shows no enhancement. Look at this. Even the kidney is infarcted, right kidney is normal. Even part of the spleen is infarcted. This is a very life-threatening condition. Your surgeon must go in very quickly there and deal with the vascular problem. Again, this is central abdominal pain. I think we ran for too long, isn't it, Professor? I think we go to the last. Go to the last slide to finish. And some other time we can talk. TB and Crohn's disease, this needs a special session. Okay, I want to go to the last slide now. So to summarize, right upper quadrant, do ultrasound. Right lumbar, CT KUB without contrast. Right iliac region, do ultrasound, and if it's complicated, do CT. Hypogastrium, do ultrasound for males and for females. Left lower quadrant, we do CT KUB. Again, the loin, CT KUB without contrast. Ultrasound for kida. For the epigastric pain, you do chest X-ray. A surgeon asking for chest X-ray. Yes, he needs it. He wants to see if there is perforation. And central abdomen, immediately expect a serious problem. Be prepared. Okay? And do contrast CT and wait for the result. Wait for the result. Inside the X-ray, you will find a problem that you need to act on. And the best thing for a surgeon is to interfere as early as possible. Ladies and gentlemen, I'm sorry for starting late. I'm sorry for keeping you for too long. And قلوبنا معكم, in my heart with my people in the country. And the Nile used to smile for us. At that time, we were always working together, cooperating together. I think the Nile is angry now and is punishing us for not being working together and for other things that you know better than myself. Thank you very much and good night. Thank you very much, Professor Azia. I was honored to have you with me tonight.
Well, thank Mohamed. Before giving the mic to Mohamed Abbas to probably see if there are no comments, I really missed to introduce Mohamed Motasim. And I think, as you see, he's really a committed teacher to both, I mean, students, residents, and I think this is probably genetically predisposed because, you know, his father is Bagi, who is the director and the founder of Omar. And I think many of the listeners probably have graduates from that school. Well, Mohamed probably reminds me of the surgical club because he has been a very active member and has got a rich library. And usually his comments, I really highly appreciate. The surgical club, as you know, probably been introduced by Professor Zakiddin early, a long time ago, and used to be on Sunday, 2 hours in the morning. Professor Daoud lectures theater in Khartoum Teaching Hospital. And both of them now are not there, but I mean, we're looking forward probably to revive both the Professor Daoud lecture room and the hospital. And the thing about Mohamed Hagiga and the late Professor Omar Biliary, usually is a serious club. They like it to be really an active thing of interactions. It's not a lecture as used to be now. And usually there comments and they trigger actually this discussion, and very hot discussion. It is actually being attended by the students, by the registrars, and by the consultants. And the club used to go up to the level of the consultants and down to the level of the students, and then they give a summary. And then we hope that will be back to the hospital to serve actually the three categories actually. Mohamed was a member of the Department of Surgery at that time, but now he's in Saudi Arabia. We look forward, probably we hope that he will be back sometime. But I mean, as you know, very committed teacher and has got a lot of things. And he has actually been having a TV program for the public, a very interesting program earlier on. Well, thank you, Mohamed, and definitely we look forward to see you back in other aspects. You made it very actually attractive for us. Mohamed Abbas, now you can take the floor and probably see if there are any comments or questions. Mohamed?
We try to get Mohamed on. I'll call my assistant. Ali, can you get Mohamed Abbas on, please? Pardon? I am. We seem to get to unmute Mohamed, and then he would unmute himself.
I see.
But my assistant is, bless him, in another continent. My assistant, you know, is a dentist, so he doesn't know what I'm talking about here. Okay, except the teeth in the dermoid, in the dermoid cyst, the teeth. And anybody can unmute himself and get in. Mohamed Abbas, please enter first.
On behalf of Sudanese Serial Club, we really thank Professor Mohamed Muhtasim very much for this very elaborative and informative session. And we hope to see you in the future, as Professor Rashid said. And we have great thank also to Professor Rashid Ahmed Abdullah for his very dedicated attendance and participation effectively and mentors this innovative platform of learning due to COVID-19 and this situation. And we hope to see all of us and all of our seniors to go back in hospital. Really thank you very much, sir. Thank you very much.
Thank you very much, Mohamed. You're very enthusiastic and you managed to recruit me, but I was eager to have this honor and join this club. You remind me of my good old days when I was a young man. Right.
الو السلام عليكم.
عليكم السلام.
الله يسلمك. عندنا الدكتور عماد صلاح حسن من مستشفى الحرس. الحقيقه سلامي لاساتذتنا بروفيسور رشيد، ويعني جميل انه نسمع صوته، وجزاكم الله خير بروفيسور محمد المعتصم. It was really a very rich and enjoyable talk. As an internist, I really appreciated and found it very useful, actually, very enjoyable and very practical. بارك الله فيك يا بروفيسور، مشكور على جهدك. مشكور يا بروفيسور، بارك الله فيك.
شكرا عماد. You have a physician in the house now, not an ordinary physician. This is a top level physician. We are proud of Imad here في الحقيقة. He is doing a great job. He's an academic and he has actually رجل متصوف علميا. Actually, I call him like that. And he is great. It's great to have you on the audience.
بارك الله فيك يا بروفيسور، بارك الله فيك.
Okay, in the interest of time, we thank you very much for being with us, and we look forward to any future opportunity to serve you again. Assalamu alaikum. Thank you very much. Thank you.